Hi, this is Angela with Propel for Crohn's disease. We are so excited to bring you the fourth interview in an ongoing series designed to educate patients, caregivers, supporters, and the GI community as a whole about the latest in Crohn's disease research and technology. In this video, we talked to Dr. Michael Dolinger, who is a pediatric IBD fellow at the Icahn School of Medicine at Mount Sinai in New York City. Dr. Dolinger talks about the emerging technology of intestinal ultrasound to monitor disease mechanisms, progression, and treatments. We hope you enjoyed this fascinating discussion, and we hope that you'll join us in advocating for wider availability of this very promising tool. Thank you.
Thank you very much for joining us today. We're really excited to talk to you. And I'd just like to maybe start by having you introduce yourself as opposed to having me do it and probably butchering your last name, as my name gets butchered a lot. So I'll have you introduce yourself. Tell us about your area of research, why it's so exciting, because we think it's exciting, and where you are today and where you see it moving over the next few years.
Thank you. Thank you for having me. My name is Michael Dolinger. I'm the Advanced Pediatric Inflammatory Bowel Disease Fellow at Mount Sinai in New York. So I completed my pediatric GI fellowship and am board certified in pediatric GI, but have stayed an extra year to do research in intestinal ultrasound for monitoring an inflammatory bowel disease. And definitely we'll go a lot more into that, but I always like to start with my overall goals and how I got there is that I have a lot of family members with Crohn's disease, and my wife has a very severe case of Crohn's disease. And having lived through those experiences at home, I think shapes you, that you can see the best doctors, be on all the latest medicines, and you still feel so unequipped and prepared to deal with everything, and you want more and you want better. And I really made it a goal early on to somehow make lives better for children with inflammatory bowel disease and adults, but really focusing on children to do my part to move the needle forward and really focusing on making their lives better however I could. And that led me to want to come to Mount Sinai actually initially because I wanted to train under Marla Dubinsky, who I thought was doing really innovative research, and she is such a dynamic mentor who is never settling for the status quo and doesn't accept anything less than perfection for our patients and really wants the best. And I thought that would be a great match, and it really was. And ultimately I told her my career goals, and she said, hey, well, I trained in Canada and we had started to use ultrasound. It's not used in the United States. And I think there's a real opportunity here in multiple facets of inflammatory bowel disease to change how we diagnose, monitor, and assess our inflammatory bowel disease patients. And I think we should bring it here to Sinai. And that is how my research interest in intestinal ultrasound started. I actually didn't know it was even possible to do 4 years ago. Before I started training, I didn't know it existed for IBD, despite thinking I knew almost everything. And I really was humbled to go overseas to Europe to learn how they were using it, and that's how it came to be at Mount Sinai and came to be my passion and career and research interest.
That is really amazing. And thank you for that, for all of that introduction. I'm obviously sorry that you've had those personal experiences to draw from, but I'm convinced, knowing a lot of physicians who either have IBD or family members with IBD, it really does make you, I think, a better physician and more empathetic. So I appreciate all of that, and obviously where you are as well. And as somebody who has a daughter with IBD, I think of Dr. Dubinsky as a guru in the field. So definitely a good place for you to be. I'd like to hear a little bit more about your training in Europe and sort of what you learned there and what you've been able to bring back to the US and how you all have adapted it, and what is it exactly that you're doing at Mount Sinai with ultrasound? How is that fitting into the, to all of the other types of surveillance that patients will have?
Yes, there's a lot in that question. I'll try and unpack it one part of it. If I forget one part, definitely remind me. So I went to first to Copenhagen for the first part of a training with the International Bowel Ultrasound Group, which is a group of experts who have been using ultrasound in Europe, Australia, Israel, and Canada. And it's a small group of really 10 to 20 experts who had been training younger gastroenterologists and fellows to use ultrasound for disease monitoring. And it is really a hands-on course. And that is the only way to learn ultrasound or any procedural skill, is to do it on as many patients with inflammatory bowel disease and healthy patients as possible, to start to see the possibilities of what you can realize with just a simple ultrasound. And then the training continues with actually becoming proficient in the skill and getting certified through the International Bowel Ultrasound Group. And that's doing enough monitored hands-on exams to say, okay, you're competent to do an exam, which through the group is 40 monitored exams. But I can tell you that in reality, it probably takes 10 times that amount, 400 or so, and matched with traditional imaging, MRI, or even colonoscopies, to feel competent to use that in a visit with a patient to make treatment decisions. And so that brings us to how we use it at Mount Sinai, is that I completed the training, and then we spent most of the pandemic in 2020 in June acquiring a machine first, which requires a large capital investment from the institution to get a high quality machine. Ultrasound traditionally was thought that it wasn't high definition enough to view the intestinal wall, but now the quality is so good. I tell people that it's like looking at a TV from 1980 to taking the most high definition screen now. If you put them side by side, you would think you are not even seeing the same thing. And that's exactly what ultrasound is like. We can see the bowel wall layers down to the 0.1 millimeter. And it's really incredible when you're actually looking at the images on a screen at that crisp definition. And that allows you to make really informed decisions about how your understanding a patient's disease is behaving, because I can actually see it affecting the wall layers. I'm not just guessing what's going on. We can actually now see it. And so what we decided to do was to spend the first 6 to 8 months scanning every patient with an ultrasound that we could in the IBD center. And I had carved out most of my time to just put a probe on everyone's belly, no prep, no fasting, no contrast. And we would scan as many people as we could in a day, 15 or 20 ultrasounds per day, to really understand the different way Crohn's and ulcerative colitis behaves. And after that, we said, okay, we've been right 300 of the past 320 times. That's as good as any test that exists. Let's now use this for treatment decision-making. And that really moved us forward into the next stage of how we use ultrasound. So now anyone who comes here at diagnosis, we characterize their inflammation in the bowel wall and where it's located and how it behaves with an ultrasound before we start them on any therapy. And it doesn't have to be a biologic therapy. We use the same concept for anything that we do, is that we want to remove the inflammation, and we want to see that with our eyes on ultrasound. It can be diet, it can be something pill, it can be alternative medicine, it can be a biologic, it can be a trial. We want to see that your inflammation goes away. And we are using ultrasound to do that. And the biggest thing that we've actually seen from our patients is that even down to age 4 and 5, they're gaining a new understanding of their own inflammation. Maybe parents were even reluctant to talk about inflammatory bowel disease and use certain terms in front of their patients, their children. And when we put the pictures on the screen, kids and adults really respond to images and color. And they actually understand that when I show them that there's increased blood flow in their colon or intestine, that's why they may not be feeling so good. And I think I can see the light bulb go off in the visit or the child, and then I can see the parents respond to that, and it really creates this visceral emotion that doesn't typically come in a traditional clinic visit. And then the counter to that is we actually watch it go away. And as they see that, it brings another emotion when you pull up the image that was just 8 weeks ago so abnormal to them being completely normal. And a 5-year-old completely understands it better than certain physicians. They'll understand exactly what's going on. It's really special. And there is no other test that we have at the moment that a child or an adult can see in real time with their physician. They're not talking about results that happened a week ago. We see it on the screen. We don't know what's going to come. That we see it in real time. And then we make decisions as we're still doing the scan. We're still talking about what this means and how that affects them and how we're going to change or stay on the same treatment. And it just really makes it, I would say, somewhat of a magical experience for a lot of our patients, that we can transform care just by putting a probe on their belly, and it empowers our children to own their disease. And really, it's very special, is, I would say, the broad answer to that question.
I love that answer. You know, you don't hear very often that a medical procedure is magical. And I think it's a great term. I think you said some really important things there about what some of the benefits are. You know, you said empowerment, you said it's visual, it's real time. Obviously it's non-invasive, but could you talk a little bit specifically about what you see as being the advantages of ultrasound?
Yeah, so the number one thing is the reproducibility. So we need non-invasive markers to monitor inflammation to know that it's getting better. We know that if we can take away that inflammation, that outcomes are better. Patients have less complications, less surgery, less need for steroids. And for children, they're going to grow and develop better. So we need a way to monitor that really closely over time, repeatedly, and have it be reliable. The best way to do that is to directly look in. We can't scope everyone because it is invasive. It is, you know, there is risk, there is anesthesia. The next best thing is visualizing the bowel wall. And for some patients, it's actually better because their disease affects more than just the mucosal layer you would see with a scope. It affects all 5 layers of the bowel wall. And the real advantage of ultrasound is we do it every single visit. So a patient who has had 7 ultrasounds, you can map their own natural history of their bowel wall with ultrasound over time. And we actually do that for a patient. We'll bring up a slide in the visit of their bowel wall 60 weeks ago, 50 weeks, 40 weeks, and we'll show the change over time. And you could say, okay, this is what this has done. This is what happened during this visit. This is what happened during that visit. This is when we made this change. And because it's so visual, it doesn't require a knowledge of literature. It doesn't require understanding even about Crohn's disease. People understand when things are bigger, they're inflamed. And when things are red and angry, it's not good. And when those go away, they're much better. And so we can get this tight control of inflammation with ultrasound because it is so repeatable. There is no contrast. There is no preparation. There is no fasting. I'll have younger kids eat a lollipop during the exam. We'll have them have snacks. I'll have them use an iPad. All that can happen if they're, you know, and we're talking 2 and 3 years old. Everyone else is really interested in what's actually going on the screen. I think that is the true benefit as this point of care serial monitor of inflammation, that we can show people how tight control really works.
And a lot of the questions that I've seen around intestinal ultrasound is, you know, is it reliable? Is it a good enough measure compared to something like a colonoscopy? Can you talk a little bit about that, whether it's a reliable test to monitor inflammation?
Yeah, I think that we need more data to convince people. But once you do it and you do it enough, it's very easy to understand and know when it is reliable or not reliable for that patient. And the majority of time, 90–95%, it is. And I think that's part of understanding anything you're doing with inflammatory bowel disease, is that it really has to be personalized for the patient. You have to go in understanding that every single patient is truly different, and you have to know what tests represent their inflammation and how best to follow it and how best to work with them. And ultrasound may not be ideal for a certain patient. You have to have a certain level of expertise to convey that to maybe a family who is hopeful that it would be the right test for them, and they're the 1 out of 10 who it's not. You have to understand that it isn't the best test for certain patients. And I think that that's really important in getting this as a more accepted modality of monitoring. There are definitely studies that show it is as reliable as MRI or a CAT scan. When you have 2 radiologists who read MRIs, they may not always have the same read either. There's about an 80% reliability there. And so ultrasound is very, very similar, is that no, you're not going to have perfect reliability in terms of how 2 people interpret the test, but it's just as good as MRI or CAT scan, which people don't realize is not perfect either. And so I think we keep striving for that perfection, but recognizing the limitations is really crucial as the person who's doing it. And the last part I will say is that we have done a lot of ultrasounds at the exact time of colonoscopy. And so we know that a certain measure of thickness of your bowel wall means with a 99% certainty that you don't have inflammation. And that a certain measure of the thickness of the bowel wall means that with a 99% certainty you do. And there's definitely a gray zone in between, but most people fall into one or the other. And then it's a really, really, really helpful test.
Yes. And another potential benefit too is, especially for pediatrics, but I'm sure it's true for adults too. A lot of the reason people don't necessarily want to enter clinical trials is because oftentimes they have to get scoped, and sometimes multiple times. I can imagine a scenario where you're doing this instead in the context of a clinical trial. It might really help enrollment. Would you agree with that?
Yeah, and we're actually working towards that, getting a formal ultrasound report and way it's done for clinical trials is a next big step to have this becoming an accepted modality. And we're actually working on it for a new therapy here at Sinai, incorporating ultrasound as a addendum or a subset of results along with colonoscopy and traditional imaging. And I think for children, especially where we struggle to get therapies approved and trials are much slower than adults, this can really be a benefit to improve numbers and improve our trial results even. Because I think when I have talked to people from the pharmaceutical industry, they actually don't understand what their medicines do to the bowel wall and when they do it. So I don't think they know if their medicine's going to make changes to the bowel wall at 4 weeks or 8 weeks. They know if people feel better, and they may know scope data, but they don't understand what the full thickness of their medicines are doing. And ultrasound actually will provide more information to understand how well do these medicines work. And I think a lot of the medicines don't work as well as we think is because we're not capturing those patients who have inflammation beyond the mucosal layer. And we fall into this false sense of comfort that we're treating the patient and making them better. But after 2 or 3 years, the medicine stops working because we never fully gained control when we thought we did, if that makes sense.
That makes complete sense. And I think it's so incredibly important. I'm a big believer in more data is always better. And it allowing you at every visit to capture that data. And as you said, tracking that through every visit, through the weeks and years, I think it's just such an incredibly important reservoir of data, both for the individual patient to allow eventually some precision type of approach, but also more broadly for studies to look at on a patient level, okay, what's happening to patients over time with all of these different treatments that are available today. How are they affecting the bowel wall? Because you're right, for regulatory approval of a drug, you don't have to know why it works. You just have to know that it does.
Yeah, and I think one of the things that we don't understand in Crohn's disease after all this time, and we mentioned it off camera before, is there's a lot we don't know. And one of the main things we don't know is actually how does inflammation start? how does it start from outside in or inside out? And how does it involve all the layers of the bowel wall? And we're starting to think that ultrasound may be a way to tell us, for patients who have had surgery already, unfortunately, and have had a resection, we then are now using ultrasound early once we've taken out any sign of chronic or active disease in their bowel wall, to follow the changes over time and see how Crohn's disease comes back and how it behaves, and is it from the outside in or inside out. And I think all of this data will help shape our future therapies and treatments to really overcome this kind of ceiling and plateau that we've hit for so long, is that we're just not capturing new information. And I think we need to be doing that in obviously multiple facets at the same time. And so my expertise and interest is really characterizing how this transmural inflammation starts to occur in our patients. And that, I think, will be eye-opening.
I think that's absolutely brilliant and a great thing to focus on. I look forward to hearing more about that or reading more about that. Maybe we'll have you back to talk about that at some point. I did want to talk a little bit, because I know as people are going to watch this, they're going to say, I never heard of this, or maybe they've had a routine abdominal ultrasound, but they've never had the type of ultrasound you're talking about with somebody who's trained with the right equipment and looking for the right things. What is it that has been a barrier? You talked about Europe, but what is it that has been a barrier, and not just in the US, I think in Canada as well, really in North America? We just haven't seen widespread use, or even, very limited use to date. Very few centers that actually do this. What's the problem there, and what are the solutions?
Big question. If I have the answers right, hopefully it won't be such a problem for so long anymore. But I think there are obviously multiple different issues. One of them is that in the United States, especially, is the healthcare system, is that a lot of people, whether it's you like it or not, are in medicine to make money. And there are a lot of vested interests in making money. And I really do not have that interest. And a lot of people in pediatrics do not have that interest. And we want to make lives better for children. But the healthcare system values ordering tests that maybe get a lot more reimbursement and make more profit for the hospital or healthcare system. MRI and CAT scans certainly make a lot more money. We're talking 10 to 100 times more money than a simple ultrasound. And that alone has led people to order more, whether they realize it or not, as there is definitely a money and value system at play. But I think then there comes the point that started to happen, and people did that before they had ultrasound as an expert modality. Now that we have a few centers that are expert in ultrasound, the issue is really a lack of training and time. And again, comes down to money, is people want to see reimbursement for ultrasounds because that will support their time. But the truth is that's not going to come for some time. So you need an institution that values this for their patients to say, we are going to take 2 years and train you to bring this here and invest $500,000 to make this part of our care to change the lives for thousands of patients. That has to come from a much higher level than someone who's really excited to do it like me and wants to learn. I'm sure there are hundreds, if not thousands, of people around the country who want to learn and want to bring this to their patients. But for a lot of reasons, they may not have the time. Their institution may not be so supportive. And I think that is slowly changing. Especially during the pandemic, has brought up a lot of health equity issues for our patients. And I think they are realizing that ultrasound is a great way to start to move that needle in the right direction. And we've now had a lot of interest from different institutions in the United States. And I'm happy to say that I think over the next 10 to 15 years, it really will change. And I'm hopeful in the next decade that we will have 1,000 centers doing it rather than 20 in Canada and the US combined, probably 3 in the US and only a handful in Canada. Will have everywhere you go, everyone will be getting this care, and we'll be able to do really high quality research that changes lives through that way. So I think there are a lot of barriers. but I do think that there is a lot of interest and excitement around this, especially now, to remove those barriers that hadn't been there maybe for the past 2 decades.
Yes, and the only thing that I will react to in what you said there is the 10 to 15 years, because I know many of us who are either patients or caregivers, we get told 10 years, 15 years all the time. And there are so many people who've been living with Crohn's for a long time, who've been hearing that for decades. And
Yeah.
I think one of the big learnings for me from the pandemic, and one of the reasons I love this organization, Propel, is because we're just, we've learned from the pandemic, but we also know we don't have to be satisfied with these relatively slow, amorphous future timelines. Like, we really can do big things quickly with collective will. And like you said, where you sort of maybe put financial considerations or ego or anything else aside, and you just do the right thing for patients. And we've seen that happen over the last 2 years that we've all lived through. So I'm hopeful that it's something that can happen much sooner. I'm hopeful that people will advocate in their own institutions, both on the physician side and on the patient caregiver side, to see this come to those institutions. And I know one of the things that's going to help that is, I think you're running a training program now.
Yeah.
So if you want to tell us more about that a little bit, that type of thing is going to help move the needle tremendously, because to your point, it sounds to me like it's sort of like being a pilot. You need to have a certain number of hours to have the comfort to do it.
Exactly. No, you're so right. It could happen overnight if we really wanted it to, from a macro perspective. And here it has completely changed the care that I give and at Mount Sinai, is we do it for every single patient, and we are not waiting for 10 years. So it's really exciting. It's hard to even tell that to people when they're not seeing it day to day. But we are hosting the first international bowel ultrasound group training course specifically for the United States and Canada, to come here to New York, so they don't have to travel overseas, especially in the pandemic, which has slowed things down for hands-on training, in the fall of 2022. So this coming fall, where we're bringing 8 experts from around the world, including myself and 2 from the United States. And we're really going to train 36 academic interested centers and faculty and fellows from around the country, strategically from different places, so that they can be the next group to help this exponential kind of rise in the use of ultrasound in North America. And so having 36, hopefully, if half really take it on with interest and get trained and do the requisite scans over the next year to 2 years, then they'll be able to train other people at their institutions and their local communities. And that's how it will really spread. And so I am huge in not keeping any of this here at Mount Sinai and trying to get as many places as possible to do this. And the first way will be through this training course, but we've actually had 3 institutions come here for more than a day at a time to learn how to do it, buy a machine to their institution and start that process early. And that gives me a lot of hope that people aren't waiting around even for training courses, that they recognize the value here and want to bring this. And hopefully more and more places do that faster and faster. So it's a really exciting time. And hopefully it keeps going very quick.
Yeah, it is really exciting, because there aren't always things that we know that would almost definitely improve both patient care and our understanding of the disease today.
Yeah.
If you implement this, that starts today. I mean, it's truly low-hanging fruit in the IBD space, like you said, Crohn's, and you see for all of it. And I'm incredibly grateful to both, the senior leadership at Mount Sinai and to you, not just for bringing it and kind of shepherding the program and building and creating the program and using it to help patients and to understand the disease better, and then passing that knowledge along, like you said, not keeping it to yourselves, and being very, very kind to share that and train others as well to help patients everywhere. So I'm incredibly grateful to all of you. I think what you're doing is amazing. I've seen, more and more papers coming out recently on this as well. So hopefully we will see even more people, both on the physician side and those who follow some of that literature become more interested in this. So really, really fascinating. And I want to thank you. And I just want to open it up to Annabelle or Natalie to see if they have any additional questions to ask.
I have a couple. This is really exciting, and I have to say I want to put this video out very fast because I just find it exciting. I'd like to reiterate a couple of things just to make sure that I understood properly. So I understand that it's much higher definition than previously, certainly much higher definition than when, for example, I was pregnant and got, way back a long time ago, where I could barely make out anything. I'm guessing that it's all very, very clear. So because of this high definition, you can sort of see mechanistically what the disease is doing. Is that right? Is that correct?
That is right. So, and I really didn't have this understanding until you see it, is that the bowel wall has 5 layers, and you can see how mild inflammation affects the bowel wall, how moderate and how severe, how it distorts the layers, how every patient's different. Some might have more thickness and chronic damage. Others might have more increased blood flow and acute swelling, and some might have a combination. And you can really characterize that for each patient. And there are even multiple other little things that you see on the ultrasound that make it so personalized. And then you see it change, which is also kind of revolutionary in that you're seeing it change in almost real time. To see how that is healing itself, right, is really incredible.
So the levels you're actually able to see the different levels pretty much.
And I explain it to patients. It kind of looks like a zebra stripe. So it goes like white, black, white, black, white is the 5 layers. And I'll always say that to the patient. Wow. And everyone who I say that to as they're looking at their bowel wall on the screen can pick it out on ultrasound. And they're like, oh, I don't know if I want to look at it. I don't know if I'll know what I'm seeing. By the time I'm like, oh, well, let's show you. You don't have a choice. And they look on the screen and we identify the pattern. They can follow their bowel wall and they know what layer. They understand that maybe it's not the mucosa, maybe it's the submucosa. And we're talking an 8-year-old who didn't know that 5 minutes ago, and they could recognize it throughout the rest of the exam. It's fascinating.
Yeah. So I have a feeling, and I don't know if this is going to happen, but people who see this, patients and their caregivers, are going to want this. They're definitely going to want this. And so we talked about the barriers of not having enough people trained around the country. And what do you say, you might end up getting phone calls from people wanting to have this done. So how can we advise them and that sort of thing? Do they just have to sit back and wait and hope that their institution will eventually adopt this?
I think, we obviously can do it for certain patients, but that really isn't the goal, because this isn't a one-time test. You need to follow it over time, and it needs to be your gastroenterologist, and your relationship with your gastroenterologist is the most important thing. You need to really trust your doctor and talk to them and work with them, as this is a relationship that you build upon over years. But we do have patients who will come here just for an ultrasound, who I will then communicate with their doctor in New Jersey or Connecticut, and then we'll bring them back in 2 months and we'll work together. In centers who this may be a little bit further away but really want to use this, those physicians recognize and they've gotten their patients here who they think it may be valuable, and it's a great experience of collaboration.
Okay. All right. And finally, do you have, you talked about this training that's going to come up in the fall. Do you already have all of the trainees that have they already signed up, or is this something that's opening up right?
It opened up in the middle, a couple of weeks ago, and it's open until March. and it is a first come, first serve. So if institutions do see this, we do have a lot of interest, which is great. So I would get an application in if I could make a pitch for someone who saw that. Because with two people being equal, it will just be the person who, applied first is how we're taking it, just so we don't exclude anybody who really wants it. But it is open to apply right now on the International Bowel Ultrasound Group website.
Okay, excellent. Thank you. Natalie?
I have two things. First is a question, and second is a comment or a statement. We know that Crohn's disease can affect anywhere along the gastrointestinal tract. And obviously there are individual patient variations, and it sounds like it's a very personalized and individualized approach. Are there any limitations in terms of areas that cannot be visualized? Like who would be an ideal candidate for this type of screening or this type of monitoring, and who would not be an ideal candidate?
Great question. And definitely there are ideal and not ideal candidates for this based on where their disease is primarily affecting. So patients who are ideal, I'll start there, are patients who have Crohn's disease and have disease affecting the end of their small intestine called the terminal ileum. That's the most common area and a great use for ultrasound to follow. Anywhere along the colon is another great use for ultrasound. It's actually easier to visualize the colon than it is the small intestine, except the rectum, which is really challenging. So that leads to the limitations. Patients with proctitis or just distal rectal disease, ultrasound is really not a good tool to assess their inflammation. Where we use it in those patients is if they come in when they're well controlled with no symptoms and all of a sudden they have symptoms, we make sure their disease hasn't extended into their colon, not by a colonoscopy, but by ultrasound. Because if you do a stool test for inflammation, it's not going to differentiate whether you have just disease limited to your rectum or it's gone further up your colon. Ultrasound is an amazing tool to give you a lot of confidence to say, no, it's still limited to your rectum, even though it hasn't shown disease before in your colon, it still doesn't. Another place where it's really not as reliable is in the high up small intestine. You have 17 feet of small intestine, not just the end of your small intestine. And ultrasound can visualize it, but it's really hard to track. And so you can definitely miss areas. If you have a patient who has inflammation in the middle of the small intestine, you've seen on ultrasound, you can follow it, but it's not a good way to detect inflammation in the middle of the small intestine. You're definitely going to miss a lot of patients if you're using it as that modality. You don't want to do that. And so it's recognizing these significant two limitations as you're doing the scans and having at least one gold standard colonoscopy to benchmark with, and maybe even another cross-sectional imaging or a capsule endoscopy to help give you a full picture at the beginning, and then you use ultrasound going forward.
Great, thank you. And my last comment, not so much a question, but more a comment, and I'm not sure how you could measure this, but I speak from my own personal experience as a longtime Crohn's disease patient for many years. We know that there are so many direct costs associated with Crohn's, but there are also these indirect costs, and the psychological impact of having invasive tests done. I think I can probably count 25 colonoscopies in my life. So this is just very refreshing and hopeful to see a non-invasive option for disease monitoring. And I just think it's just wonderful. And I'm very hopeful and optimistic that this is something that will be used widespread at many centers in the future. So thank you for bringing this to the GI community.
Yeah, you're exactly well said. And I will add that not only non-invasive, but I actually think it's better than a lot of the tests we're currently using. So you get the double combination of improving what we're assessing and making it much better for patients. So I think that's what makes it really exciting for me. And I'm just so excited to be here. And I thank you for having me.
Thank you.
Yes, thank you so much for coming, and it is very exciting. And I also love the idea that we can figure out better, perhaps, I love this idea of being able to figure out whether it's coming from the inside out or the outside in terms of inflammation. I think that's going to be really helpful. So
yeah, we will figure it out. It's not a maybe. We will figure it out. It's just going to will take a little bit of time.
yeah. Okay. Music to our ears.
Yeah, on this incredibly positive note, because I think we're all very much aligned that we are excited and hopeful and optimistic and thankful for all the great work you and others are doing. And we just wanted to thank you again for coming, for doing this, making patients aware that this is happening, and caregivers. And hopefully we will talk to you again in the future when you have great results to tell us.
Thanks.
Thank you.